So if you guys remember, right, we've been spending a lot of time, and we did a little bit of it yesterday, right, talking about, obviously the clinical exam and how any good clinical exam, when we talk about concussion, generally includes, right, a symptom survey, a full clinical exam, neurocognitive testing, which we haven't talked about yet, but we will, right, next week, and also balance testing, right? So we've identified these three domains, right, that we have to cover in any good exam for sport-related concussion or MTBI. Okay, so let's get into some details in regards to balance testing, particularly BESS. All right, so obviously, as we already know, okay, BESS testing, balance testing in general, is only one piece of our multimodal puzzle, right? So if you guys remember, who can tell me, right? We talked about generally, kind of these three areas and the importance of a multimodal approach when diagnosing concussion and treating concussion, right? Why is that important? Why is a multimodal approach to diagnosis and management of concussion important?
So that we don't potentially miss certain aspects of a TBI or concussion, or just blatantly miss a concussion, period.
Right, absolutely. So ultimately, Josh, you're absolutely right. We have a greater chance of identifying a concussion in someone that is truly concussed if we're using these three different, these different measures of examination as opposed to just one. Okay, so let's go over this, right, as a refresher, right? So ultimately, and we'll cover this again in a second, and I'll put this up on Moodle, but the multimodal approach obviously is important because this allows us to obviously establish higher levels of specificity and sensitivity. So to review those terms, because we get confused very easily as people, right, going over these terms, something that is specific, okay, if we have specificity, all right, we are talking about identification of a negative result, okay, or absence of a disease, right, or condition in someone who is actually negative or healthy. Okay, so they're truly negative when they don't have it, right? Truly negative, so negative result, negative test, true negative. Okay, conversely, sensitivity. Okay, this is identifying the positive result or the presence of a disease or condition in someone who truly has it. Okay, so positive test result matched with the positive disease or diagnosis. Okay, so obviously the true positive. So the patient has the condition, in this case, concussion, and tests positive for it, right? Based on the examination that we do, right? A true negative, the patient does not have the condition and tests negative, right? And obviously, we have examples of also false positives and false negatives. Who can give me an example of a false positive? What's a false positive?
When you get a positive result, but it's not like it should have been negative.
Okay, so essentially a test result that is artificially positive, right, in the absence of the disease or condition, right? And then a false negative being what? So we know what a false positive, but what is a false negative? Any thoughts? No? Okay. Today's hump day. You guys don't seem very talkative, but it's fine. It's fine. Okay, so false negative, right? So obviously a negative result, right, in someone or in an individual who actually does have, right, the condition. Okay, so false positive, false negative. Okay, background information. Going back to this graph that we talked about on Friday, okay, and this paper, right, we've kind of been using this paper as kind of the baseline for our rationale, right, of looking at a multimodal approach. So, and I got a couple questions from you guys or from one of you at the end of class on Friday, specifically about this paper. Well, let's just I'll just talk about this briefly. So Dr. Jacob Resch, out of the University of Virginia, it was the author on this paper, and he essentially asked two basic questions, right? What's the specificity and sensitivity of individual measures of concussion, being symptom score, balance testing, neurocognitive testing, right? And do they have the ability to discriminate between someone who is concussed versus someone who is not concussed by themselves? Okay, and then the second question that he asked, when we utilize accepted clinical guidelines, like those put forth by the international, by the concussion sport group, right? Utilizing those recommendations and guidelines, what is the specificity and sensitivity of those individual measures? And then he also looked at obviously these measures when used as a cluster as well. Okay, so check it out. So if we look right at the three measures that he used, I know you guys have seen this before, but I'm going to explain it again, right? So obviously over here in the first on the left side, okay, letter A, right? So this is sensitivity and sensitivity rather, as calculated using basically a discriminant analysis. So when these tests are used by themselves, right, impact when used by itself in the absence of clinical guidelines only identified 55% of concussions that were present. Okay, if that makes sense. Okay, sorry guys. Yeah, so the head impact score, right, only identified 7.5% of concussions, and that's actually a symptom scale, right? And then we have the sensory organization test, which is a balance test, okay? Only identified 72.5% of concussions when used by itself, okay? When we put the three of those tests together, okay, we correctly identified 80% of concussions, all right? Conversely, we go over to obviously side B, right? And we can see that when utilizing impact, okay, alone, and this is with the symptom survey inside of the test, right? We identified 95% of concussions correctly, all right? With a sensory organization test, which is a balance test, ironically, in utilization of clinical guidelines, balance testing actually had decreased sensitivity when used within the interpretation of clinical guidelines to detect concussion, all right? And then obviously symptom scale, so 97.5% there. But then when we put all three of these tests together and interpret them within the context of clinical guidelines, 100%, okay, sensitivity, meaning that we correctly identified 100% of concussions every time. Okay, sorry about the ball noise in the background, but okay, cool. All right, guys, so the BESS test, we used it yesterday. You guys used it to look at me, right? And all of my wonderful errors that I made, like 74 of them, all of those. That was amazing, right? But, okay, the BESS test, a little bit of history, right? So the BESS test was created by Kevin Guskowitz at Mary's alma mater, UNC Chapel Hill, right? UNC Chapel Hill has essentially been one of the pioneering institutions, along with the University of Virginia, when it comes to concussion research, particularly within athletic training. And so this test actually today is widely used by ATs to obviously assess both baseline balance and balance performance after concussion, right? So there are, and I know that for us at Gustavus, we utilize BESS in a different way. We utilize that obviously with sway balance, and that's how we do a lot of our assessment. But it is very common within athletic training itself to utilize this measure when evaluating for concussion. So if we remember correctly from yesterday, when you guys did this on me, right, we have 6 conditions, all right? So we take the patient through those conditions on both a firm surface and a foam surface, right? So we have a double leg stance, single leg stance, and a tandem stance, all right? And obviously each trial lasts for 20 seconds, and the number of errors within that trial is recorded every time, right? And how many errors do we allow within a 20-second trial, guys? What's the max? 10, perf. Okay, perf. All right, good job. Okay, here we go. So obviously you can see, okay, that we have, this is the BESS test. So we obviously double leg, single leg, and tandem stance, both firm and foam here, right? So, and one of the things that we will actually see in a few slides is that the non-dominant leg is always used for single stance, and is placed behind the dominant foot in the tandem stance. Okay. One of the things that we'll see here in just a little bit, right, is that people, right, and this is honestly the weakness with our concussion assessments. One of the biggest weaknesses that exists is that with our assessments for concussion, there is a known practice effect. Okay, what does that mean? That means that if someone does this, long enough, or they have enough experience with it, they can actually learn it. Okay, they can improve, right? And they can do so well at it over time that actually masks positive results because they have essentially adapted, right? Either neuromuscularly or cognitively to the conditions of the test. And we'll talk about potentially how to deal with that here in the next couple of weeks and some alternate strategies to address the practice effect. All right, so obviously guys, what counts as an error? We know this already. Okay, double leg stance, single leg stance, and tandem, right? So obviously, as you guys saw yesterday with me, right? Any eye opening, right? So if my eyes were to come open, right? My hands came off my hips, right? I fell out of the stance, which happened like a lot yesterday, right? And then lifting the heel or toes off of the pad, right? And so if I stumbled out of my stance and stayed there for greater than 5 seconds, that counts as an error, right? Hip abduction and single leg of greater than 30 degrees counts as an error, okay? So what do you do though? Like, here's a question. So what do you do? Like, let's say you had me on the pad yesterday and I was doing single leg balance, right? And I made an error, right? But in making that error, my hands came off my hips, my hip abduction greater than 30 degrees, right? And my eyes opened. Is that 3 errors or 1? Okay, so all 3 of those actually, if they occur during the same postural deviation, so if I'm in my stance and I deviate and all of those things happen at the same time, okay, that's 1 error. Okay, that's 1 error or 1 postural deviation away from obviously my center of gravity, right? So if all those things happen at one time, it's just 1 error, right? And then I get back in position. So Josh, I see a little, maybe, so you said 3, okay, initially, but does that make sense? So just within the confines of the test and how those things are counted, right? If all those things happen within the same error, that would only be counted as 1. All right. So a little bit of boring, dry research here. Yay. Okay. So obviously, one thing that the BESS test often gets compared to is measures of splay balance, right? And so BESS actually displayed higher validity, right, in both the single and tandem stances. Here's a question for you guys, okay? And one thing that's been really difficult is the BESS in the double leg stance has actually not been able to be validated within the double leg stance. Why do you think that's the case? Why would we not be able to validate this against other measures in a double leg stance condition? Who has an idea of why that would be the case? No? Okay. Well, no, I thought the chat blew up for a second. Okay. Just kidding. All right. So remember, guys, even with me, right? I have bad balance even at baseline, right? How many errors did I make in double leg stances today for a morphome? Who remembers? 0. Okay. I made 0 errors. So generally speaking, even in individuals who are concussed, it is extremely rare, right? Extremely rare, if not, never happens to see errors in the double leg condition on BESS, right? We just don't see it. Now, what about, what would the difference be like potentially in someone that has, God forbid, maybe they have had a stroke or they're actually, they've fallen and they've hit their head and they have a bleed, right? What does that look like potentially, right? In a double leg, in a double leg stance? Do you think it'd be more likely to see an error in that situation or no? Quite possibly, right? Yeah. So remember, because as we talked about, The changes in concussion are temporary, right? This is not something that's going to alter the neurological integrity of tissue, or the integrity of the brain, right, or spinal cord. These changes are the trauma itself and the pathology itself is generally resolving. So we wouldn't expect to see the double leg balance error in people that have concussion, right? Not to say that it can't happen, it's just extremely rare. Okay, so what factors, guys, what things do we need to be mindful of, okay, with BESS? What if we're doing this on the field or doing this maybe in a post-game situation, right? So some things to keep in mind with BESS. So obviously people who have functional ankle instability generally perform worse on BESS test, okay, than those that don't. So if we have someone that, and it's a patient that we know well, okay, who has sustained a concussion, but also has a history of functional ankle instability, right? These people have been known to perform worse on BESS than those that have no history of ankle injury, which makes sense. I mean, it's pretty intuitive, right? Okay, so obviously doing the test while someone is taped or braced, right, has been shown to artificially inflate or improve BESS scores, right? So it's going to be really important to do this with any tape jobs or ankle braces off, right, when we're actually doing this test, potentially in the ATR or on the sideline, right? One thing that's also obviously extremely important is that fatigue, right? So someone who is obviously fatigued or tired, if we have someone who comes off the field after a series of a football game or whatever and is out of breath, may perform worse on the BESS test if fatigued than if they've had a chance to essentially recover prior to the BESS test or doing the exam. Okay, one thing we talked about that we kind of referenced a minute ago, and this is going to become really, really relevant to us when we talk about neurocognitive testing next week, right, is the practice effect. So remember, we have the ability, and this is we have two big weaknesses, right, when assessing for concussion. Let's talk about one of them. What's the biggest weakness that we've covered thus far with our concussion evaluations? What's the thing with our symptom surveys and our scales that is potentially the biggest potentially confounding factor in identifying concussion? What is it? So if you think back to your exam, whoop, chat, holler, yeah, Brianna, excellent job. So patient self-reporting, okay, meaning that the patient self-reports their symptoms. Beautiful job, Brie. Okay, the patient self-reports their symptoms, and so this is very much a subjective measure, right? When it comes to essentially symptom reporting and reporting of symptoms. All right, that's one of our biggest weaknesses. But conversely, okay, on the objective examination side, particularly in balance testing and neurocognitive testing, as we've mentioned, there can be a practice effect. Okay, you can actually learn how to take these tests. And we've had problems in the past in previous institutions, and I'm sure this has happened at Gustavus as well, with people cheating on these tests. Happens everywhere, right? Making sure people will take cameras and things like that, their phones, into the room, and they will take pictures of the screens. Many different types of things can actually happen with these tests. So it's really important to have a very tightly regulated testing environment because people will cheat on these tests. Anyway, but aside from that, the practice effect has been one of the biggest factors, meaning that people that, if you can imagine, right, taking a baseline test every single year, coming in and rebaselining every year or two as a collegiate athlete, and then sustaining concussions at maybe 2 or 3 over the course of your collegiate career, and sitting down with this test multiple times throughout your career, do you think that you would essentially start to develop an expectation or learn what to expect from it because you've been through it multiple times? Absolutely, right? Absolutely. So that is one of the downfalls with neurocognitive testing. but also with our BESS test, right? With balance testing, that just due to the nature of being a collegiate athlete, right? And due to the nature of the neuromuscular demands that all athletes undergo, right? You can actually not only learn this test, but you can actually get better at this test or improve, have, improved performance over time simply due to adaptations in neuromuscular control, right? If that makes sense. So ultimately, right, with that, and sorry, some other things here, right? And obviously hydration status, ironically, has not been shown to affect BESS scores. So that's not something that we necessarily have to worry about at this point, at least. Okay, obviously, as we talked about this, right? So we know, I mean, obviously I've been beating this over the head, right? Like crazy, but obviously we have to do a cognitive testing, symptom score, balance testing / WOMS, which we'll get into, right? So we have to do all these things and take them into account, right? When making a decision about diagnosis, and also a decision about return to play, right? But what's the most important thing, right? What is one of the biggest key factors that we've learned so far, right? In diagnosing concussion? Always, always, always do what? Okay, so obviously always do a comprehensive clinical exam. Cranial nerve exam is extremely important, right? Anyone that obviously displays a central dysfunction and or focal deficits should be referred, right? All of these things are incredibly important when conducting your exam. And every single exam that you do should be comprehensive, right? I think that goes without saying at this point, but ultimately, all of this has to be included. Okay, so that's it. But I will see you guys on the morrow, okay? For class face to face, okay? And we'll continue to obviously dig into this. We'll do obviously another lab tomorrow, at least with BESS, potentially even also, if we can, do a little bit of stuff with sway as well. And we'll kind of compare and contrast those measures and what exactly it is that we're looking for there, okay? But I hope that you guys are having a good Wednesday, okay? You guys are kind of a quiet bunch today, which is uncharacteristic for all of you, typically very boisterous. But anyway, okay, you guys have a good day, all right? And I will see you guys tomorrow. If you need anything, let me know, please. All right, I'll be away from my computer for a couple of hours this afternoon. I've got to go to Burnsville for a site visit out at TRIA. But if you need anything, just email me, okay? All right, you guys are great, and I will see you tomorrow. Bye.
Thank you.
Thanks, Wade.
Bye, guys.